Prasad. Thank you, Raja, for the initiation. Probably it is something like I'm doing a rerun of what I have done on July 2nd, okay, because many people were not able to join, and like it was a request from our own friends. So like I'm very happy to be sharing my knowledge. It's not something like I know much better than you. Whatever I know, I'm just trying to tell you, because whatever I have learned is mainly from like interaction with you and patients. So we'll start here. I have more than about 140 slides. Probably it may take about 1.5 hours up to, I think, but on a Sunday evening, taking 1.5 hours time. First, I should thank the family of all the doctors who had allowed you to participate, because being a Sunday, I know how difficult it is going to be to say 1.5 hours. I'm going to be like trying to gather some knowledge through interaction. Okay. I'm unable. Right. My humble greetings to all my teachers for helping me to come to this level, because whenever I speak, I have been groomed. Probably I have tried to copy so many of the teachers. I have got knowledge from many people. So I cannot name any individual teacher as such, but a whole lot of teachers. Without them, I would not have been here. My humble greetings to them. The scope of this lecture will try to cover basics, because many a times we are always thrust something without giving information about what we need to know really. Then I'll talk about normal lung and abnormal pictures or abnormal features in the chest X-ray, in the radiology. I'm concentrating only on X-ray chest, nothing but X-ray chest. The first X-ray, you know, Dr. Ranjan and his first X-ray picture with the wedding ring. So the tissue absorption of X-ray varies with each tissue and how it appears. Air is always black in color, but when it absorbs more, as in bone, it becomes white. Your fat and soft tissue, they are shades of gray. Air is black, bone is white. Okay. Normally, we take X-ray in children in the supine position, but normally in adults, in our undergraduate, we used to see only PA picture. PA picture means the distance between the X-ray tube and the cassette is 6 feet, 180 centimeters. And if it is going to be a PA, means the beam comes from posterior aspect of the patient to the anterior aspect of the patient, where the anterior aspect is in close contact with the X-ray cassette. So PA. AP means it is the opposite. In supine, most of the pediatric X-rays are supine. That means the distance between the X-ray source and the cassette is much less than 6 feet. The X-rays are not parallel when they impact the thorax, so you can have wide shadows or enlarged shadows of structures in the anterior aspect of the chest. What is it? Heart. You may have as heart size which is slightly more than normal in a supine film. Whereas in a PA film, because almost the X-rays are hitting the chest parallel to each other, they are not going to magnify any of the like structures inside the chest. Even though like they may not meet the quality of a PA X-ray, supine film is sufficient for us to make a diagnosis of most of the problems which is there in the lung. Basically, we need to look at only four in the sense: penetration, rotation, inspiration, and movement artifact. These are the four basic parameters. Before we read an X-ray, these are the four basic parameters what you need to look at. Here, the topmost on the left, the penetration is not good. What you are able to see? You are able to see everything in white. You are not able to see beyond this. You don't see the intervertebral disc spaces, poor penetration. What happens here? The medial end of the clavicle is not equidistant from midline. You have a rotation, so the heart appears as if it is more in the right side, whereas because the position is not proper, because it is a rotated film, you have something like the whole mediastinum shifting to the right side. Then when you take an X-ray, always they have an increased respiratory rate, and the experience of the radiographer helps in taking a good X-ray, but many a times we are bound to see X-rays taken in expiration. We'll see, like expiration means this is the anterior end, this is the posterior end of the rib. Whatever is in contact with the vertebral body, that is the posterior aspect of the rib. So this is the posterior aspect of the rib. The anterior aspect, this is the anterior aspect. The anterior aspect of the rib, always free, floating. Why? Because the costal cartilage is not visualized. So they appear as if it is floating freely, but no, it is in conjunction with costal cartilage, which articulate with the manubrium sterni. So we'll not be able to see the full part because costal cartilage is not opaque. So you are able to see the anterior ends of the ribs. The first four anterior ends of the ribs alone are seen. This is a completely expiratory film. And when the child is taking an inspiration, if the radiographer takes a film like that, it is something like an out of focus image what we click when we take a photograph. You are seeing everything as double, so you may not be able to appreciate any pathology, or you may diagnose a pathology when it is not there. So what do you mean by a good inspiratory film? The dome of the diaphragm, it should correspond to the anterior end of the 5th to 7th rib. If you're able to see the anterior end of 5th to 7th rib, then you can say it is an inspiratory film. If you're able to see up till the 7th rib anterior end, it is a very good inspiratory film. Here what do you see? The red blocks, 1, 2, 3, 4, 5. This is the anterior end of the ribs. So it is a good inspiratory film. Expiratory film, it exaggerates the heart size and bronchovascular markings. You are able to see 1, 2, 3 only. You are able to see the anterior end of the ribs. Why you are able to see an exaggerated heart size? Because the diaphragm is attached to the undersurface of the heart. In full inspiration, the heart is pulled downwards. But if an X-ray is taken in expiration, the heart will appear larger. There will be crowding of vessels. The lung bases sometimes can mimic a pneumonia too, or it can mimic an atelectasis too. So before you try to interpret an X-ray, that is why you need to look at the phase of respiration. Rotation, I was telling, this is the midline which passes through the vertebral spine. Okay, the medial end of the clavicle should be equidistant from the midline. If it is not so, you need to interpret the X-ray like cautiously. Okay, if there is rotation to the right, your manubrium sterni or superior vena cava can become prominent. If it is a rotation to left, your aortic arch will appear very prominent. And sometimes you can have a rotation being the cause for one lung appearing darker than the opposite side. See rotation, you see the medial end of the clavicle, left clavicle is close to the midline, whereas the right is farther away. So what do you see here? This is the manubrium sterni. You're able to see the manubrium sterni. Don't mistake it for a lymph node. So that is why whenever you have a rotation, your interpretation has to be like cautious. Okay? Penetration. A correct penetration means you should be able to see the intervertebral disc spaces through the heart shadow, that is through the cardiac sellout. Sometimes there can be over penetration, sometimes there can be under penetration. And unlike previously, now all the X-rays are digital X-rays. So the radiographer will try to give a good picture. He will think what he does will be good for the doctor, but many a times they may not be good at making changes. And they can give a picture like this, wherein everything will be dark. You are able to see the intervertebral disc spaces. Everything will be darker. You may miss out a lesion in the lung. Sometimes they will give a picture like this, wherein everything will be white. Obviously, something is not all right with the right lung, but unless they give a proper picture, whether it is fluid, whether it is a mass, whether it's a pneumonia, will not be able to see. Sometimes you'll be able to see exaggerated bronchovascular markings, but look through the vertebral spaces. Are you able to see the intervertebral disc space? No. This is a mistake by a radiographer. And sometimes, like you may see under penetration, wherein you may not be able to see much. So before you interpret a digital X-ray, you need to look at so many different things so that you are able to differentiate whether the child has got a real problem or it is because of the techniques of processing the digital X-ray, which is causing something like an image with which we need to be very careful. Always the position of the scapula, either in AP or PA, make sure it is away from the lung window or away from the lung parenchymal shadow. Why? Because sometimes if it is not positioned properly, we can mistake the medial border of scapula for even a pneumothorax. So always we should make sure that when the radiographer takes the film, he should make sure the scapula is rotated away from the rib cage. And beware, there are 4 hidden areas. What are the 4 hidden areas? One, most of the time, is the apex of both lungs. Second, it is the hilum. Third, it is the cardiac. Why? Because something here behind the hilum will not be able to make it out in a frontal X-ray. Frontal X-ray means your supine AP film or a PA film. So these areas, so if something is behind the hilum, we will not be able to make out. If something is behind the heart, we will not be able to make out. Same way, if something is behind the diaphragm in the posterior, costo-diaphragmatic recess, we will not be able to make out the pathology. But on both PA and AP, both the diaphragms are well defined. If a dome is obliterated either in part or whole, that means there is a disease in the adjacent lower lobe. Probably when we talk about the sellout sign, we'll come more in detail about this. So for a purist point of view, that means for a radiologist, these are the 10-point checklist. For a radiologist, I'm not telling for a pediatrician. If the pediatrician also is able to follow the 10-point checklist, what the adult radiologist or a pediatric oriented radiologist is going to do, well and good. What are they? PA or AP film, satisfactory inspiration or not, rotation is there or not. Then look at the heart size, whether diaphragm is, both the domes are well defined or not. Then look at the heart border, look at the hilar, look at the bone, then look at the hidden areas, hidden areas. I told you apex, hilum, cardiac cell and diaphragm. Then correlate with the clinical problem of the child. But most of the time, including me, when I ask for an X-ray, I just put query bronchopneumonia. I never tell about fever, respiratory rate, saturation, intercostal indrawing, nothing. I just put LRTA or RRTA. That may not give the proper clinical condition for the radiologist to interpret properly. I know what I am doing is not right, up to the mark. But when I don't have any help, when I need to write the X-ray requisition form, I try to finish off doing it without wasting my time, because I have many children to look for in the government setup. Okay, in government setup, this is fine. In private setup, still old habits die hard. So even when I came to the private setup, still I don't write fully. So I am not giving a good information to the radiologist so that he can interpret properly. But we always say radiologists may not interpret properly because the fault is with me, because I am not giving full information about the child. But I want the radiologist to make a proper interpretation of the X-ray. Many times the fault is with me because I'm not giving a clear picture. If we give a clear picture, the radiologist will be able to identify even before he sees the X-ray what the child's problem is and try to look at what he needs to look at specifically. So something basics. Next, whatever we do, we are not tuned to looking at a lateral X-ray. Why you need to have a knowledge about lateral X-ray? Because if you have a problem in the X-ray chest, immediately our hand goes to write a CT chest. But you know the radiation dosage in CT chest. Is there any way to reduce it? Is there any other way to make out or find out what is happening in the child by any other methodology in imaging? Yes, if we take a lateral X-ray, many times we will be able to avoid a CT chest too. But we are not taught about lateral X-ray. I won't say not taught. Probably we have not learned the way how to interpret a lateral X-ray chest. When do you do a lateral X-ray? Only when you have an equivocal frontal X-ray. Frontal X-ray means an AP view or a PA view. A lateral X-ray rapidly excludes or confirms most equivocal abnormalities seen on a PA or AP film. It tells us whether the problem is in the anterior part or posterior part, which lobe. It also tells us or shows us the tricky areas behind heart, in front of hilum, behind the dome, behind the domes of diaphragm, also in the costodiaphragmatic recess. It is very useful, especially in this time of COVID. And many times, even if you send for CT, they will first ask for RT-PCR, nasopharyngeal swab, and negative, only then you can get a CT. So lateral X-ray, we can use a lateral X-ray. How to decipher a lateral X-ray? First, we can take part by part. See, this is a lateral X-ray. Lateral X-ray, that means you put the X-ray plate in the right lateral chest wall. You project the X-rays from the left side of the chest wall so that it goes and hits on the cassette which is placed on the right lateral chest wall. First, what you can see, a manubrium sternae anteriorly and the vertebral bodies posteriorly. Then you will be able to see the dome of the diaphragm too. The lung, it appears black, darker inferiorly compared superiorly because you have a lot of soft tissue shadows. What are they? Scapulae, your like probably the neck muscle, smooth muscle, the soft tissues, and like even your scapulae comes into the picture. So the upper half appears a little bit whiter, whereas the lower half of the lungs, they appear darker. Then what happens? You insert the heart and the arch of aorta in a lateral X-ray. So once you place the heart, it is just behind the manubrium sterni. Then the arch of aorta, it just goes and curves in the prevertebral space. And you will always have a straight line behind the posterior inferior border of the heart. That is nothing but your inferior vena cava. Okay? Then what you're going to see? You are going to see the main pulmonary artery. The right pulmonary artery is anterior. Your left pulmonary artery is posterior. Then add the trachea. Trachea comes in between the arch and the like descending thoracic and descending thoracic aorta. Then it has got the upper lobe bronchi. So this is how it is. So this is the right pulmonary artery, the left pulmonary artery. The purple one is the right upper lobe bronchi. The brown one is the left upper lobe bronchi. So in real life, this is how I told you the upper half is a little bit less dense, like a little bit whiter because of soft tissue. Then you are able to see the manubrium sterni. Then posteriorly you are able to see the vertebral bodies. Then you are able to see the cardiac silhouette. Then you are able to see the trachea, two openings, and then you are able to see the diaphragm, both the diaphragm, and you are able to see the space behind the heart. Most of the time, this will be a very difficult, tricky area, hidden tricky area, which you will be able to make out in a lateral X-ray. Normally, two domes. Like you will be confused, which dome is right, which dome is left. The right dome is visualized all the way from front to back, whereas the left dome will be visualized only from the back of the cardiac shadow to the costophrenic recess posteriorly. Why? Because the left dome of diaphragm, the heart obliterates the lung diaphragm interface anteriorly. Now I have taken a close-up view of the diaphragm alone. You have one green triangle, one red triangle. The red triangle you see, you will be able to like see from back. This is the posteriormost part of the left dome of diaphragm. This is the costodiaphragmatic recess. From there, you trace up, trace up, trace up, trace up. Up till this, you're able to trace. But after that, what you are not able to see because your cardiac shadow, it interfaces with the diaphragm, so you're not able to see it separately because it is attached. Your right dome of diaphragm, you start from anterior, it goes all the way down posteriorly. You are able to see it through and through. Okay, always the diaphragm will be something like clear crystals, pencil line like shadows. Now we are going to difficult area. We are going to travel to difficult area, that is hilum. Why? Because hilum is a very crowded place. The artery account for most of the hilar shadow. The right main pulmonary artery is in front of the right main bronchus, whereas the left main pulmonary artery, they hook over the left main bronchus. The location of the pulmonary arteries, you are able to see it in this X-ray. You are able to see the two shadows here. What are they? You're able to see? One here, one here. So these are the upper lobe bronchi. The right upper lobe, the left upper lobe. And sometimes if there are fluid in the fissure, you'll be able to see it in the lateral X-ray. The horizontal fissure, the oblique fissure, right and left. The position can vary between the right side and left side, because right side has got two fissures, left side has got only one fissure. So the oblique lines, the horizontal fissure, the oblique fissure will not be opposed to each other. There will be some difference if there is fluid. Then you look at the heart, which area is anterior. The right ventricle is anteriorly placed, the left ventricle is posteriorly placed, and this is the left atrium. This is the both right and left atrium, what you are able to see. Whereas in a frontal X-ray, it's different. It's a right atrium, it is a right ventricle, this is the left ventricle, left atrial appendage. But here in a lateral X-ray, you don't see the right atrium at all. Like what you see is only the left atrium. I'm sorry for the mistake. This is not right atrium. This is the left atrium, what you will be able to see here. Okay. Right ventricle, left atrium. Okay. Right ventricle, left atrium, left ventricle. I told you a small vertical line. The small vertical line is the shadow of the inferior vena cava. And in a frontal X-ray, you'll be able to see it sometimes in the right heart border as a straight line. The lower vertebral bodies are darker because there are less soft tissue and the scapula is not superimposed. But if there is whiteness here, it invariably indicates there is a pneumonia, a pathology, most often a pneumonia. So if you are going to look at the chest X-ray, lateral chest X-ray, what you are supposed to see: vertebral bodies, domes of diaphragm, the hilar, then change in density across the cardiac silhouette and abnormal lung densities. But always try to correlate the findings with the frontal X-ray. Don't try to interpret the lateral X-ray as such. Only we are going to take a lateral X-ray only after doing a X-ray chest AP or PA. So now we have got into a very tight spot. We'll try to get us relieved from that tight spot by looking at more easy things: the alveoli and interstitium. The terminal bronchioles are this one. This lead on to alveolar ducts, and the alveolar ducts terminate in the alveoli. We know alveoli is the place for gas exchange. The interstitium of the lung surrounds not only the alveoli, but also the alveolar duct and the terminal bronchioles. So the interstitium provides two functions. One is mechanical function. It acts as a scaffold. It supports the alveolar wall. It has a dynamic function that it allows the fluid, cells, and nutrients pass into and out of the interstitium. So two functions, mechanical and dynamic function. So many a times, like in CMEs, in like conferences, they will say, or in discussion, they will say alveolar disease or airspace disease. What do you mean by that? Both are used interchangeably. Airspace disease is nothing but is always meant alveolar disease. That means filling of the alveolar air spaces with abnormal material. Filling of the alveoli, it should be filled only with air. But if it is filled with blood, pus, water, cellular debris, or a combination of these, then you can say you can have an alveolar disease. it can lead on to ill-defined margin, or sometimes if they coalesce, it can give a segmental picture. This we don't understand. What do you mean by that, sir? Yes, this is what I mean. If there is a airspace disease, it can, if it is filled not with air, but with debris or fluid, this is how you see. That means ill-defined margin, fluffy, blobby, whatever you can say. But if the fluffy or ill-defined margin, it keeps on coalescing with each other, then you have a segmental lesion or a lobar lesion. One in the left lower, one in the right upper. So this is how. It just keeps on changing. Day 2, it may be like this. Day 4, it may be like this. It all depends on when you take the X-ray. Then they will say interstitial disease, airspace disease, interstitial disease. Interstitial disease means like only when there is an abnormality in the interstitium, either due to edema, inflammation, or fibrotic thickening, the interstitial pattern will be seen in an X-ray. It can be linear, reticular, or reticulonodular. So this picture may tell you or may help you to understand what you mean by interstitial shadows. Linear, reticular. This is a child's X-ray. This is a X-ray of a child at 829 gram weighing child who was ventilated for 39 days and came out of oxygen by around 11th month. Child was on home oxygen. I was looking after the child only from the 3rd month of age, after the child was discharged from a tertiary care hospital. So every day the grandmother used to call me, because I tell the grandmother, call me every day, because oxygen dependent, sent the child home with oxygen. Every day morning, call. Every day how the child is, saturation, with the help of home oxygenation, okay? And we do it by the help of oxygen concentrator, not by cylinders, oxygen concentrator, which needs only a power supply, which can deliver up till 10 liters of oxygen. This child had a viral infection at the age of 3 years. That is the time this X-ray was taken. You are able to see all these linear streaks, interstitial pattern, bronchopulmonary dysplasia. This, like as the child grows older, this is how the X-ray picture looks like. This was taken when the child had an intercurrent viral infection. That is why hyperinflated chest. Again, see here, you are able to see the linear reticular shadows. So both are interstitial pattern. If we see interstitial pattern in a child who was previously normal, we always say this looks like a viral pneumonia. If it is a long-standing one, probably we think of bronchopulmonary dysplasia, something else. But this is what the interstitial pattern looks like. Okay. So now we had looked at pneumonia. A combination, alveolar and interstitium. This is what a typical picture of a viral pneumonia. Sometimes during rounds, we'll say this child looks like having a wheeze, like this X-ray, hyperinflated chest, and a picture like this, wherein you have both alveolar fluffy pattern as well as interstitial pattern, something like reticular or linear shadows. This is the para-hilar peribronchial infiltrate, para-hilar around the hilum, peribronchial wherever the bronchi goes, peribronchium around the bronchus, or like subdivisions of bronchus. So you have problem in the alveolar and interstitium. This is what you have most often in a viral pneumonia, especially like including bronchiolitis. Normal lungs shows nothing other than a large vessel and occasionally a lung fissure. The normal bronchial wall, if it is visualized, it is usually the end on view. a normal alveoli, normal interstitium, normal lymphatics, none of them are visible. So keep it in your mind that these things, normal alveoli, normal interstitium, and normal lymphatics, none are visible. Now we'll come to silhouette sign. Just by looking at this silhouette, you know this is Charlie Chaplin. So silhouette means outline of an object, a solid object, representation of such an outline filled with black color or any color. It is used as a picture. This is what we call it as a silhouette. This is a silhouette of Charlie Chaplin. Silhouette sign, what does it mean? It indicates an intrathoracic lesion which touches a border of either heart, diaphragm, or aorta and obliterate the border on the X-ray chest. It is only a misnomer. It actually refers to loss of part of the silhouette. Suppose for Charlie Chaplin, if you don't see the stick or if you don't see his feet, what is it? This is what we call it as a silhouette sign. This is a silhouette. When part of the silhouette is not seen, we call it as a silhouette sign. This is a misnomer. So here you are not able to see the left dome of diaphragm. This we call a silhouette sign. Here you are not able to see the left border of the heart. This we call it as a silhouette sign. Here we are not able to look at the right dome of diaphragm clearly. This we call it as a silhouette sign. Here we are not able to look at the right border of the heart. This we call it as a silhouette sign. Okay. It is a deliberate misnomer. Okay. Actually refers to loss of part of the silhouette. So whenever pneumonia is suspected, we always look for a silhouette sign, whether it is positive or not. Not only in pneumonia, but it can be applied to any water density lesion in contact with mediastinum or diaphragm. Not only like a pneumonia, but also in mediastinal masses. Here you are able to see the shadow behind the right border. You know something is there behind the heart. You are able to see the right heart border clearly. So something is there rising from the mediastinum. Probably this may be a duplication cyst. So silhouette sign, this is a mediastinal mass. So you are not able to see the left border of the heart properly. So this is in the same plane as the heart. So this is how we interpret, and we tell, probably even to confuse you, we tell you as a silhouette sign. So you need to understand what a silhouette sign is. It obliterates the border of either mediastinum, heart, diaphragm, dome of diaphragm, or even the arch of aorta. Absence of a silhouette sign tells us where the shadow also is not situated. That means if you're seeing a silhouette like this, you know this is not in the right middle lobe. This is behind. This is in the lower lobe. This is how you can interpret. Okay. But we need not break our brains for a silhouette sign. This is many a times when in a conference or meeting when they say silhouette sign, don't get confused. Okay. Now, there are white areas in the lung. Whenever you have white areas in the lung, we almost always say it is a lung consolidation, but the same thing can happen with lung atelectasis or lung collapse also. Whenever you have a lung collapse, you have a volume loss, which is seen evidently. Why do you have a white shadow when you have a collapse? Because there is no air within it. The affected lung occupies only a smaller volume with no air in it, but mucus secretions back up and collect in the alveoli. So any fluid accumulation within the lung, it will appear white. That is why a collapse, even though it is smaller in size, it appears white. Especially if there are some exceptions. If the lobar collapse is very rapid, sometimes it can collapse to a paper thin structure. Okay. And normally, you know, there will be not only evidence of volume loss, but also displacement of fissure, hilum, trachea, and mediastinum, along with elevation of the dome of diaphragm and decreased spacing between the ribs. These are all the characteristics for a lobar collapse. Also, there will be evidence of overinflation of the either unaffected lobes on the same side, or the opposite lung may have overinflation because it has to compensate for the loss of work by this collapsed part. And in the compensated part, the vessels can be more widely separated compared with the normal lung. This is how it can be. There is an atelectasis in the upper lobe. The bronchovascular markings, the vessels can be seen wide apart compared to a normal X-ray where there will be spaced normally. Okay, and the collapsed right upper lobe, the remaining part, the middle lobe and the lower lobe, has to do the work of the upper lobe also. So it will have more air. So this will appear darker compared to the normal lung too. So these are some of the characteristics. Whenever you have an atelectasis, these things will be there. So know more about that. Collapse of the right lower lobe, you'll be able to see the cardiac sellout correctly. If there is a collapse of the left lower lobe, you'll be able to see through the cardiac sellout. If you have the collapse of the right middle lobe, the right heart border will not be seen. Okay, this is a sellout sign. In a lateral X-ray, when you look through the lateral X-ray, this is the part occupied by the middle lobe, and because this is airless, this will be like a cone, okay, with the base in the outside, in the anterior part. Okay, this is how an atelectasis will look like in the right middle lobe. So there are certain mimickers for collapse. If there is a mimicker for collapse of the right upper lobe, means it's nothing but your Assegas fissure. For the middle lobe, the mimicker can be a depressed sternum. For the right lower lobe, there can be an accessory fissure. For the left lower lobe, can be a hiatus hernia. But for collapse of the left upper lobe, it is slightly different. Normally, we don't see the collapse of the left upper lobe, more common in the right side. I don't know why, either in the right lower lobe, left lower lobe, or right upper lobe due to aspiration. But collapse of the left upper lobe, not commonly seen in pediatrics. But when there is a collapse, you need to identify it. Well, it is very different because there is no horizontal fissure on the left side. There is a V-like density which covers most of the left hemithorax because of the lack of aeration of the collapsed upper lobe. The left heart border is obscured either in part or in whole, and the left hilum is elevated. Only when you look at it, you will be able to make out. You see the normal right lung, you know you are able to see the left lung, but it is not very clean. Not very clean in the sense you are not able to see the air shadow, you are not able to see a straight line. So this is how a collapse of the left upper lobe looks like. This is how a collapse of the left upper lobe looks like. You know there is volume loss, you know there is some hypodensity, like decreased, like more whiteness here. If you take a lateral X-ray, you will be able to see this line. This is the horizontal fissure and your atelectasis of the left upper lobe. But normally, when you have a picture like this, if you take a lateral X-ray, this is how a collapsed left upper lobe will look like. Okay. We'll come to hilum. Hilum, most of the time, you have pulmonary artery and pulmonary vein. Pulmonary artery is one which comes from your right ventricle. Pulmonary vein is which comes into the left atrium. Okay? We are more bothered about this hilar point. this hilar point, always the left hilar point will be slightly higher than the right hilar point. The hilar, like normally in an X-ray, why do you need to make out the hilar point? Because sometimes if there is an atelectasis, a hilar point can get altered. If there is going to be an atelectasis of the right upper lobe, the hilar point will be higher up. Number two, if there is going to be any hilar node or a hilar node, this point will be filled up with a convex margin. That is why you need to know about the hilar point. Okay, this diagrammatic representation, but in real life, this is how the hilar point will look like. And this is where your nodes can come and occupy if it is going to be in the right hilum or in the left hilum. Okay. Pleural effusion, you know, most of the time you have a concave margin. If it is only occupying the right pleural cavity, you will have mediastinal shift. Sometimes there can be a very thin rim of fluid and as in a parapneumonic effusion too. Sometimes there can be fluid in the minor fissure or in the horizontal fissure wherein it will look like this. Okay. Sometimes there can be subpulmonic fluid where it may be very difficult for you to decipher what exactly it is unless you have known about subpulmonic fluid. This happens in dengue fever, especially you have fluid in the right side, right pleural fluid. Almost always we equate to dengue fever. If you take a frontal X-ray, sometimes your right tomb of the diaphragm will appear a little bit elevated, but the midpoint of the diaphragm will always be higher. But here the lateral point is higher. That means there is some fluid beneath the right lung base. If it is in the left side, again, the midpoint, the highest point of the diaphragm will be situated laterally. Normally it is situated in the center, the highest point of the diaphragm. But if it is situated laterally, you know there is going to be fluid beneath the right, right or left lower lobe. This is a subpulmonic fluid. Okay, and in the left side, there will be a wide gap between the gastric shadow, fundal shadow, and this shadow, the subpulmonic fluid shadow. Okay, so this will help us to indicate that there is. This will help us to identify that there is subpulmonic fluid on the left side. And not so common, but need to know about this because this is a basic. If there is a nodule in the periphery of the lung, then there will be, the margins will be clear, well defined, but the interface between the pleura and the lesion, it forms an acute angle. Sir, I am unable to identify. Now, are you able to identify in the upper two pictures? See, this is an intra-pulmonary lesion. You have a lesion within the lung. Here, it is able to make an acute angle between the pleura and the lesion. So that means this lesion is within the lung. Now we have another lesion in the pleural cavity, in the periphery of the lung, whether it is in the lung or pleura. Here, the margins appear a little bit ill-defined, but much more than that, the interface between the lesion and the pleura, it is an obtuse angle. Hope you are able to identify that. You are able to identify this is an obtuse angle. Okay. And for lesion coming from the rib also, it is the same. The obtuse angle will be there. So only for lesion within the lung, you are going to have an acute angle. For those lesions coming from pleura and from the rib, it is going to be an obtuse angle. I know that you're really fed up. Is there any easy way to learn X-ray? Yes, if you know the basics, you be thorough with the basics. Now we'll try to go in the easiest way wherein you can make a decision, you can make a correct diagnosis. Once you are good in your basics, you can start interpreting the X-rays very easily and very clearly. Okay, always we know X-ray is interpretation of black and white. Normally we look at only the fair things first, right from our college days to everything, whatever we buy. We go for shopping, we try to buy clothes, we try to buy something which are really good in color. But X-ray, it's only black and white, still no color. So we always try to look at white color. There are three structures which are white. What are they? One is soft tissue, second is bone, third is cardiac shadow. Soft tissue on either side of the rib cage. Bony structure, look for fracture, signs of rickets, or any mass from the bone. Hard shadow, examine the hard shadow for position, size, and shape. Now we'll come to the black. Three structures which are black in color. Yes, trachea and main bronchi, right lung and left lung, stomach funnel shadow. So three white things, three dark things. Then try to analyze in the lung, because many a times we take X-ray for the lung rather than for anything else. Compare the size of two lungs. Compare the vascularity of two lungs. Compare the hilar shadow for the position. I told you the left hilum will always be at a higher place than the right hilum. Position, find out if it is filled up or free like this, and the shape. So in the lung, you look at only three things: size of the two lungs, vascularity of two lungs, and the hilar position. Always interpret the X-ray with the clinical findings. So all the X-rays are from collections which I have got over the last, probably right from the Institute of Child Health days till now. So most of the time the X-rays are taken for recurrent respiratory symptoms with or without distress, with or without fever, or a combination of all three. Now we need to know thymus, because this is one organ, one structure which comes in different size, different shape. All these, a triangle, something like a sail, something like a bow, something like a quadrilateral, something occupying, something like atelectasis. But atelectasis means it should go up till the periphery, not stop halfway here. Sometimes it can mimic like a node too. But all these are the size and shape of thymus. So always know about thymus before we try to interpret. Sometimes if you have a doubt, like this case, if it is a thymus or if this is a node, we take the X-ray for a child with respiratory problem. We may be thinking that this child may have something like a paratracheal node here. But is it a node or a thymus? We can differentiate by doing a simple ultrasound. This was one child wherein like child's X-ray was taken for a respiratory issue. You are able to see streaks here and there. Obviously, you know, this child has had a viral infection, like probably a bronchiolitis. But we have a picture like this. I was very confident that it was only a thymus. But to prove, like, how do you say it is thymus? The father was not happy about that. So I asked for, okay, we'll go ahead and do a ultrasound. Ultrasound picked out that this is only a thymus. But always Google teacher is the one which is the godfather for most of the tech-savvy people. So they never realized what I said, what we did was right. So he went ahead and did an MRI. thank God he didn't go for a CT, but he went for an MRI. MRI, you are able to see the thymic shadow. This is what looks like the shadow. What is created here is because of the thymus. But don't try to waste your time and energy by doing a CT chest or MRI. Your ultrasound is going to tell you whether it's a thymus or not, because this thymus organ, it does not displace any structure. Wherever there is a place, just like people's nature in South India, it tries to adjust. It does not defy anyone. It does not fight with anyone. It does not push and jolster anyone. It always tries to occupy whatever small space is available. It will not cause compression to other structures. Your sonologist is going to help you by finding out whether it is a thymus or not. Now we'll come to subcutaneous tissue. You know this white shadow, both sides, it is much larger. You know that there is also fluid in the right side, fluid in the left side. This is a small baby with dengue. Like this child had a lot of third spacing. We had taken X-ray because child was having respiratory distress, but it's a finding. I used it for teaching. This is only subcutaneous tissue. This is only fluid. Sometimes this can happen with nephrotic syndrome too. But you are right, pleural fluid and pleural fluid on the left side can happen with nephrotic syndrome. Okay. And here, looking at the three white structures, one is subcutaneous tissue. Here we are dealing only with looking at only the subcutaneous tissue. This side it is clean, but this side when you come up, you have a shadow, a convex shadow, but inside that you have a calcification. What is it? You have a calcified lymph node. Most often it can be the TG adenitis calcification or TB adenitis which has healed, which can give a picture like this. But this picture which I borrowed from Thangavelu sir, and what does it show? The white structure, the subcutaneous tissue is only on the left side, not on the right side. If you are going to look at a picture like this, you have to immediately swing into action, because this is nothing but a necrotizing fasciitis, wherein you will have cellulitis only on one side. It is a life-threatening illness. Life-threatening illness in the sense, unless you remove the necrotizing fascia, you will not be able to save the child. Okay? This is a very ominous sign in an X-ray chest. You need to immediately swing into action. Your pediatric surgeon is the one who is going to help you out. We'll come to bones. This X-ray, the bones in the X-ray, the second white structure, this is a normal density bone. But coming to the left side, is there any change, any difference in the density of the bone? Yes, it appears as if someone has chalked it out. Someone has given a white color to all the bones, more dense bones. This is a dense bone disease. Once you have a dense bone disease, you have only two conditions, osteopetrosis or pycnodysostosis. You see the X-ray picture. This is one of the X-rays from Child's Trust Hospital, and everywhere they always have a documentation of the X-ray by a number, whether it is Institute of Child Health or Hospital for Children. I really do not know what these two lines are. Okay, fine. What is here is you are able to see the bones, but the bones, it is appear very less dense. You are able to see the angle of the ribs, but the bones appear less dense. And you are able to see only one humerus here. You are not able to see the right side humerus here. When you have a bone which is less dense, the only condition which makes the child to have uniformly less density of the bone is rickets. Always we take X-ray with including the upper end of the humerus. This helps us to find out whether there is anything like evidence of vitamin D deficiency, increase in the growth plate size. You have a distance, increased distance between the growing end of the bone, cupping and fraying also you can see. But much more than that, what do you see here? Ends of the bone, you are able to see bulbous ending. This again tells you that this child has got a rachitic rosary, which happens most of the time with vitamin D deficiency, rickets. Okay. I'm sorry, I don't know what these lines are. Probably it is my own, or it's something like whatever I have faced. Okay. But what you see here, you're able to look at the anterior end of the ribs as if someone has chalked it out, or someone has painted the anterior end of the ribs brightly with a white paint. Not only that, you are able to see the medial border of the scapulae and also the inferior angle of the scapulae. What is it? It is deposition of heavy metals, which gives a picture like this. This is the X-ray from Institute of Child Health. You are able to see the name, you are able to see the number also upside down. This 2311, probably it is 2003. Okay, this is a heavy metal poisoning. Why do you take an X-ray test for a heavy metal poisoning? Any child which gets admitted to the hospital as a routine, we take an X-ray test. An X-ray gives a clue to the diagnosis. You're able to see the upper end of the humerus. Why the upper end of the humerus? Again, it is painted white. Why? Because the heavy metal has deposited in the growing ends. So you are able to see the upper end of the humerus, which is chalky white. The anterior end of the ribs, as if someone has painted it white. You are able to see the scapular border. This happens only with heavy metal poisoning. Okay, you have a diagnosis even before you do any biochemistry. And you're able to see a less dense bone. The same child, after you give treatment, this is how the bones become. This is the X-ray picture before vitamin D and at the completion of treatment at the end of 3 months of treatment. Okay. Sometimes you'll be able to see a picture like this, wherein they can have kyphosis or scoliosis. If they have a scoliosis with convexity to the right, you will be able to see it is a rotated film. You see the clavicle where it is here. You will be able to see more of the right bronchovascular markings better than the left side. Don't mistake it for a pneumonia, because it is a rotated film. You have a problem. You have what to say. I really do not know what these lines are. I'm sorry, but these are nothing but exaggerated bronchovascular markings, which you are able to see it because of the rotation. Still, I don't know. Okay, we'll come to diaphragm. Diaphragm, normally you should be able to make out both right and the left side. The right dome of diaphragm is here, but the left dome of diaphragm is not here. The left dome of diaphragm is somewhere situated in the thorax, and you are able to see all your colonic loops also going up. This is nothing but your eventration. Again, this side, you are able to see the dome of the diaphragm, but still you are able to see the cardiac silhouette. Okay, these are all eventation of the dome of the diaphragm. The diaphragm is higher up in the thoracic cavity. If it is a left dome of diaphragm, which is eventated, stomach will be there in the thoracic cavity. If it is a right dome of diaphragm eventation, the liver will be in the thoracic cavity. I told you, right dome of diaphragm eventation, the liver will be in the right hemithorax. Sometimes you will be able to see something like this. This is not a pneumonia. Even though it is white in color, you just trace the right dome of diaphragm, there is a bulge here. What is it? And this is another child's X-ray. You have a swelling here, and you are able to trace out the dome of diaphragm, even though the X-ray is not very clear. This is a movement artifact, but still we are able to make out that something is not all right. But the same child's, this X-ray, when you take a lateral X-ray, you are able to see. For this, you need to make out, need not have rush in for a CT scan. You take a lateral X-ray. What do you see here? You are able to see a bulge in the right dome of diaphragm. That means it is a segmental eventration. And then you trace out the diaphragm. You are able to trace out the rest of the diaphragm. This is the right dome of, this is the left dome of diaphragm, wherein you have the cardiac silhouette. Anteriorly, you are not able to see. So when you have a problem with the dome of the diaphragm, whether it is a segmental eventation or not, your lateral X-ray chest can tell you. Okay. What is this? This is something obliterating the left heart border. But here, the left dome of diaphragm is high up. But unfortunately, this X-ray and this X-ray both are the same adolescent boy's X-ray. What happened? This is a germ cell tumor, what Yuvraj Singh had, this 12-year-old boy had, before they were able to do anything. He presented to the hospital of a respiratory hospital. They were planning to do a surgery the next day, but unfortunately, the previous day evening, the tumor burst and they had to intervene immediately the same day evening as an emergency surgery. And when you do something like an emergency, you have a chance to take care of many things. You have a chance that something can go wrong. What happened was this child's left phrenic nerve was inadvertently cut and the left dome of diaphragm palsied, and the left, they had to remove part of the left lower lobe too, and the left lower lobe never expanded. It just went in for a plate-like atelectasis. Sometimes we do have pictures like this, but don't get worried. Unless otherwise you get the previous X-rays, you may not be able to proceed further. So whenever you have a finding like this, always ask for whether they had had any previous X-rays so that you need not break your head into what is happening to the child. Okay. Now we'll come to the lung proper. This is what we normally look at. I told you lungs, whether it is both one on both sides, whether the aeration is fine or not. Is there any parenchymal shadows? Look at the airway. Anything outside the lung, pleural fluid effusion, whether there is air in the pleural cavity, then look at the mediastinum. And finally, look at whether there is any mass in the lungs. First, single lung. Sometimes a single lung can be visualized. This child presented for a respiratory infection who was thriving well, but except a mild tachypnea. These two children were in ICU, but these two children's X-ray also had opacity in one hemithorax. But these two children were acutely ill, whereas this child was not acutely ill, had only a mild tachypnea. Just a clinical history, you can make out these two children, the center and the far right. They have an atelectasis, an acute atelectasis. But this child, whether it is a chronic atelectasis or whether it's an agenesis, when the child is growing well and when the child does not have anything else except a mild tachypnea, most often it is a well compensated, which happens most of the time with an agenesis of the lung. But we can confirm either by doing a flexible scopy wherever possible, or by a CT chest, or by echo, where it will tell you the size of the pulmonary vessel. It can be atretic or it can be absent. But the clue can be the intercostal spaces will be very narrow in agenesis, unlike in atelectasis. And most of the time, they will not be in acute respiratory distress. Then look at the aeration. One look at this aeration, you know there is more air in the lung. Each lung looks like a box, a rectangular box. This is an X-ray of a child with uncontrolled asthma. That is why you have air trapping in both the lungs. You start counting the anterior end of the rib, 1, 2, 3, 4, 5, 6, 7, almost touching the 8. So on the left side, you are able to see up till the 8. The diaphragm is almost flattened. So this indicates this child has got a lot of air trapping. This happens in children who have uncontrolled asthma. Normally, the lung parenchymal shadow will almost be something like a conical one or a triangular one. Apex will be smaller compared to the base. But when the apex is of the similar dimension like the lower half, then you know it is an uncontrolled asthma. Why? Because there is a lot of air trapping. Only if it is a chronic air trapping, the apex of the lung also expands distance to this particular level. Okay. Now, you have air in both lungs, but air in one lung is more than the other side. Why do you say so? Always air outside. Take for example, take for comparison, these are all air. Air outside the body is black in color. Here, the air in the lung, one lung is similar, not this dark, but compared to the other side, this is more dark. That means air is trapped within this lung. This means the diaphragm also is flattened. So this is nothing but there is something obstructing the left bronchus, whether it is a foreign body, whether it is an endobronchial TB, check valve type, or something compressing the left main bronchus from outside. Any one of these three reasons may be the reason for this obstructive hyperinflation. More darker means more air, but you still see bronchovascular markings, so it is not a pneumothorax. Most often it is a foreign body. But many times you have a closed differential, whether it is a lobar emphysema. I still do not know whether it is a congenital lobar emphysema. How do you differentiate? Now we'll try to differentiate. Here this has got more air compared to the right side. This has more air compared to the right side. But for a congenital lobar emphysema, what should be there? There should be compression of the lobes which are adjacent to this overexpanded lobe. Here you have overexpanded upper lobe. There is a compressed lower lobe. You have an overexpanded right middle lobe. You have a compressed right upper lobe, compressed right lower lobe. So always in a congenital lobar emphysema, look for collapse of the underlying or the overlying lobe. In this X-ray, is there any other finding? When you see one finding, don't forget to look at other finding. Look at the bulbous end of the anterior ends of the rib. What does it indicate? It indicates this child also has got a vitamin D deficiency. Just because you see one finding, immediately your eye should not stop seeing other findings too. Okay? Now, sir, yes, the right lower half of the lung has got more air compared to the rest of the right upper lobe and the left lung. There is no bronchovascular marking here. So is this a loculated pneumothorax? No, it is not a loculated pneumothorax. Why? Because the differential is going to be your pneumothorax does not have a localization in pediatric age group, especially if the child had not had any ICD done or any surgery in the thoracic cavity done. Like this child has got more air in the right lower half of the lung. But you are able to see something like septations here, septations here, septations here. What is it? This is nothing but your congenital pulmonary airway malformation. Previously, we used to call congenital cyst adenomatoid malformation. Okay, CPAM. You can make a diagnosis of CPAM if you see one X-ray clearly, and if you're able to understand, you'll be able to see it in any subsequent X-rays which you come across. Then, if you have decreased air, we are talking about increased air, localized increased air, but now decreased air. Decreased air, it can happen with hypoplasia. Here, hypoplasia of the right lung, hypoplasia of the left lung. Because this again is one condition, congenital condition. You can make a diagnosis of this either by doing a flexible bronchoscopy if you have the availability, or you can do a CT scan to find out that particular side, the lung size is small, or if you have access to echo, the pulmonary artery size itself will be smaller when you compare to the left side, when you compare to the other side. And when air is absent in a localized area, we call this as atelectasis. Atelectasis, right lower lobe, like this is what you see here. Atelectasis, both lower lobes. Atelectasis, right upper lobe, and a retrocardiac atelectasis. Okay. Now we'll come to parenchymal shadows. One look at this parenchymal shadow. It is fluffy. There is small amount of cavitation. There is some fibrotic streaks. This is the hallmark or picture for a child with tuberculosis. Because you cannot give any particular definition to this appearance of parenchymal shadow in TB. Fibrocavity, if you want to say, you can say alveolar. Like you can say fibrosis, you can say cavities, you can say linear atelectasis, all will be there in TB. You have fluffy infiltrates, you have atelectasis, you have fluid. So combination of findings will be there in TB. Okay. And these are the hallmarks of TB according to our tuberculosis NEP program, Tuberculosis National Eradication Program. Hilar nodes, mediastinum and hilum. This is a miliary TB. This was taken way back. My handwriting was still good that time, 25/3/2009. Now it is something like my Talayeluthu. But that time, 2009, we were not using that much CT scan. So we are able to see miliary shadows, uniform, density, bilateral, symmetrical, more than a pinhead size here. Here you have a node, a cavity. This is a 4-month-old child who had got a AFB, field full of AFB in the resting gastric juice. This is a node with a pneumonia. All these can happen with TB, but the suggestive radiology is fibrocavitation, miliary mottling, lymphadenopathy, calcification in the hilum, even though it is not given in the National Tuberculosis Elimination Program. If you have a calcification in hilum or lung parenchyma, like think of TB as the first rather than looking at anything else. And if you have cold abscess in the if you're able to see this through the chest X-ray, that also is indicative of a spinal TB. So apart from fibrocavitation, miliary mottling, lymphadenopathy, cavitation, calcification and cold abscess also or part of TB findings in X-ray chest. Sometimes parenchymal shadows, a necrotizing pneumonia, you see a cavity here, you see a consolidation here, a consolidation with the cavity, small cavities. A necrotizing pneumonia, during treatment, sometimes you can have massive cavities like this. Don't get alarmed by this, but a necrotizing pneumonia can have pictures like this. Many a times they will have attendant empyema too, but sometimes if your antibiotics are working well, even if you have distressing picture like this, you need not do anything, you just follow them up, everything will clear, because nature gives a healthy healing hand for children like this, and where they heal, they do wonders. You give them time, it comes back to normalcy in about 3 months to 6 months time. This I had already told you. Any child who has got a viral pneumonia, going by one look at the X-ray, we say, looks like a viral pneumonia. How do you say, sir? Keep on looking at the X-ray. Here you have hyperinflation, flattening of the diaphragm. You have parahilar, peribronchial infiltrates. Parahilar, peribronchial infiltrates. This happens most often with viral pneumonia. And is there any problem here? Yes, you are able to see the trachea and bronchi, you are able to see the cardiac silhouette, you are able to see the lung parenchyma, you are able to see the dome of the diaphragm. Behind the right dome of diaphragm, you see something here. What is it? It is, you have an air fluid level like lesion. Then you ask the history. History says child has been having fever for about 10-15 days on multiple antibiotics, and you have a picture like this. So the diagnosis, your diagnosis is right, it is a lung abscess. When you give proper treatment, this lung abscess heals like a ring and it will become normal. You still have some fluid here. But to tell you, why do you say it is only a lung abscess? You see, this child has got a CT also done. You are able to see the air fluid level, not only at one level like child had lung abscess, in other place too, but you are able to see the lung abscess. Here one, here one. You are able to see the air fluid level. With just antibiotics, everything will come back to normalcy. Now we'll look at the airway. This airway, dilated bronchi. When you have a dilated bronchi, when you're able to see the dilated bronchi, you immediately jump to the conclusion, yes, this child has got a bronchiectasis. Bronchiectasis, what are the abnormalities? It can be something like tram lines. Tram lines means dilated bronchi, like maybe from the third order bronchi up till probably 14th to 15th order, you'll be able to see the tram lines. Sometimes you can see tubular shadows of the bronchi, dilated and fluid-filled bronchi. Then sometimes you will be able to see cystic cavities. These are saculations, extreme bronchial dilatations, with or without volume loss. Now we'll go back and see, you're able to see tram lines, dilated and fluid-filled bronchi. So this appearance comes with bronchiectasis. This child is having, still alive under my care, with a cystic fibrosis. Sometimes we can see picture shadow like this. What is this? We will not be able to say in which lobe it is. It will be near the hilum. You will have a horizontal, something like a thumbs up picture like this. This is a typical picture of allergic bronchopulmonary aspergillosis, because it does a dense plug with mucus and fungus within the proximal bronchi, which is dilated. It can sometimes give the picture of a toothpaste or a toothbrush or a finger and glove appearance, and upper lobes are frequently affected. Sometimes you do a CT scan for a picture like this, they will immediately give you a diagnosis of ABPA, allergic bronchopulmonary aspergillosis, even without you doing any microbiological examination. This happens most of the time in those who have asthma untreated or treated very poor, taking poor treatment. Now looking at airways, once again airways. You have shadows here, parenchymal shadows. Then you have parenchymal shadows in the mediastinum, looks like a node. Anything else you are able to make out. I told you whenever you're looking at dark shadows, you need to look at the trachea and main bronchi. You are able to look at the trachea, the main bronchi, but there is indentation, there is compression of the main bronchi. Sir, only for you, it is visible. For us, it is not visible. So what I will do, I'll try to write something here. Are you able to see the narrowing of the trachea? Because it is getting compressed by the mediastinal mass of mediastinal lymph node. This is a child who had got a perinatal tuberculosis. Is there anything else down below? Yes, down below also you have something. You are able to see a very narrow lumen here. I have not put in the bronchial wall, like left main bronchial wall, but I'm just trying to just give you a picture of the left main bronchus, that also bronchial lumen, that also is compressed and narrowed. The right side main bronchus is not compressed. Okay. This finding most of the time happens with tuberculosis because this is one condition which allows, in spite of the narrowing, to live and allow us to make a diagnosis. I will come to pleural fluid. One look at the picture on the left side, you know, this is dengue fever in a dengue season. Dengue season now, throughout the year, we have dengue cases in Chennai. So a right pleural fluid, you call it as a dengue. This again is a right pleural fluid, but what do you see here? This is a subpulmonic fluid. Where do you see the, like normally, the midline is the highest point in the diaphragm. But what do you see here? Here you see in the lateral aspect, the midpoint, the highest point of the diaphragm is in the lateral aspect. This is a pleural fluid with the subpulmonic fluid. And pleural fluid will have many avatars. That means subpulmonic fluid, fluid here, subpulmonic fluid here, sometimes loculated fluid. If you have a loculated fluid, you will have indentations. It will not be smooth, convex like, okay, like you can have, it will not be smooth, concave line. You will have indentations too. Sometimes you can have fluid in the fissure too. A parapneumonic effusion with effusion in the minor fissure too. Normally, if it is a slowly occurring or slowly increasing pleural fluid, which happens with a tuberculous pleural effusion, you have this curve, what is called as a Ellis curve, a concave line, which which has a base towards the hilum and apex towards the chest wall. This is a Ellis curve. This happens with a slowly accumulating pleural effusion. But if the child is sick, if you have a uniform density, uniform wide density with splaying of the intercostal space, you know only one condition, the pleural fluid has become a pus, an empyema. This the child will be sick child. Uniform density, there will be shift of the mediastinum, and you will not be able to see the cardiac shadow separately. Along with it, there will be widening of the intercostal spaces. And I told you about the subpulmonic fluid. Pneumothorax. Most of the time, pneumothorax, this does not give you enough time to even put in a tube. Many times in emergency, we need to do a needle thoracostomy before we go ahead and put in a needle, an ICD, because this is a life-threatening situation. Unlike an empyema, empyema also is a life-threatening one, but in pneumothorax, if you don't let out the air, most of the time the child succumbs to the pneumothorax. See, most of the time we have only a tension pneumothorax. What do you mean by a tension pneumothorax? The dome of the diaphragm is almost always flattened out, and this is how it is flattened out, or it becomes convex too, like this. Whereas in a pneumothorax which is not under tension, you will still be able to make out the dome of the diaphragm like this. Maybe in adults we can see like this, but in pediatrics, most of the time, if it is a pneumothorax, it's always with tension, and we need to intervene like as an emergency. Almost always, because there is air, it will push the mediastinum to the opposite side. Unfortunate child who had bilateral pneumothorax. Why? Because of necrotizing pneumonia. You see multiple small cavities in both the lung, and a needle thoracostomy immediately push in an ICD2. Even before that, even before we are able to push in both, the child had air leak. Air leak means you had subcutaneous emphysema going all the way up till the neck and going all the way up till the abdominal wall. You are able to see the lifted like thymus too. You are able to see the lifted thymus too. But like pneumothorax is an emergency, whether it is because of necrotizing pneumonia, nematocele opening up, or whether it's due to a foreign body, central foreign body causing pneumothorax, pneumomediastinal. Most of the time, like a pneumothorax is a life-taking one. Your simple procedure is going to save the life. Okay. Sometimes in newborn or in children with bronchiolitis who have got mucus plugs obstruction, you can have lifting up of the thymus. This they call an angel wing sign too. Okay, something like angel blessing the child. So sometimes they call it as an angel wing sign. But sometimes you can have a through and through diaphragm, like when there is a pneumomediastinum. Normally you will not be able to see any gap between the heart shadow and the diaphragm. But if you're able to see a rim of air around the heart, you can have a pneumopericardium. We look at the mediastinum. Mediastinum, like each one describes it differently. Normally, when you have a mediastinal mass, whether it is in the superior mediastinum or whether it is in the like lower mediastinum, anterior, middle, or posterior, we need to find out. What happens if there is a problem in the middle mediastinum? It usually splays. This means splays means it widens out the main bronchi. Normally it will be an acute angle. It becomes an obtuse angle. And if it is a posterior mediastinum, it will usually splay the paratracheal, paravertebral lines. This happens with cold abscess many times. What is this? This is a mediastinal node. But sometimes a duplication cyst also can be presenting like this. Whether it is a mediastinal node or a duplication cyst, it all depends on the pressure effect. Okay, these are all mediastinal nodes. But you can have mediastinal masses like this, wherein there is displacement, there is air trapping, there is compression of the left main bronchus leading to air trapping, and collapse atelectasis of the right left upper lobe too. Here, this X-ray we had previously seen, this was a germ cell tumor. The left heart border you are not able to see. Here you are able to see the left border of the heart. You are able to see the cardiac silhouette. This is a like a silhouette sign, but it is a misnomer. I said is because you are able to see the cardiac silhouette properly. This is not in the middle mediastinum. This is posterior to the heart. There is a posterior mediastinal mass. This happened to be a duplication cyst which was compressing the left main bronchus, leading to air trapping. Look at how much air the left lung has. We will come to the heart. Normally we try to look at the cardiothoracic ratio. If the cardiothoracic ratio is more than 50%, we always say the heart is enlarged. But like many a times, this may not happen. Many a times, the heart shadow may be small. For us to say the cardiothoracic ratio more than 50% is only cardiomegaly may take a longer time. If the interval heart size is going to be increasing by 2 centimeters or more, you know it is significant. This is what the picture says. Don't go by only by the cardiothoracic ratio. If it is going to be a single film at this time, you'll be able to make out. But if you have two X-rays, which shows there is an increase in the cardiac silhouette size, but less than 50% cardiothoracic ratio. But if there is an increase in the size by about 2 centimeters, you know this child's heart is dilating. And we say about left ventricular configuration when the apex is almost merging with the left dome of diaphragm. This is a cardiomegaly. Here you have a left ventricular configuration. Why? Because this child had a mitral regurg and a mitral stenosis. You had a left ventricular vein failure. So this child had a left ventricular configuration. This is a right ventricular configuration wherein there is cardiomegaly, but the apex is lifted above the diaphragm. This is a right ventricular configuration. So when you're going to look at a cardiomegaly, whether there is a right ventricular configuration or a left ventricular configuration, this should help you out to make which one is right, which one is left ventricular configuration. Sometimes you'll be able to make out pacemakers in X-ray. Pacemakers in X-ray, because many children have congenital heart disease operated now, you'll be able to see the pacemaker which is embedded in the subcutaneous tissue. Sometimes there can be only an atrial pacemaker when the tip is in the right atrial appendage. Sometimes there can be a dual chamber pacemaker wherein one will be in the right atrial appendage, the other one will be in the right ventricle, dual chamber. If it is going to be a biventricular, one will be in the right ventricle, one will be in the left ventricle, one will be in the coronary sinus. Okay? So cardiomegaly, one look at it, this is a left ventricular configuration. And this, whether it is an anemic heart, whether it is a pericardial effusion, you should be able to make out before you look at the X-ray. When the child is anemic, you know your heart is going to be dilated. But when you have a picture like this, you need to investigate further. Your echo is the one which is going to help you out, not anything else. But if you have a picture like this, you don't need any further evaluation. You know this is a pericardial effusion, a massive pericardial effusion going in for tamponade. This child will be a very sick child. Child will be in distress. You need immediate treatment. So you need to do an echo, you need to drain it, post-drainage. This is what the size has become like this, post-drainage. Sometimes if the child has got an expiratory film, you can have a picture like this. Don't try to interpret it in a different way. So that is why when you have an X-ray, find out whether it's an AP film or whether there's a whether it's a supine film, AP film, inspiratory, or whether it's an expiratory film. If it is an expiratory film, you'll have the heart shadow a little bit larger. Don't try to misinterpret it. Tubes and lines, you can have CVP tube, central venous pressure, olden days, but now you can have NG tube, nasoduodenal tube, intercostal drainage tube, ET tube, tracheostomy tube, and lines. central lines. You can have central lines, you can have IJV lines, you can have ET tubes, you can have nasogastric tubes. And what is this tube? This tube starts here, comes beneath the diaphragm, it goes into the peritoneal cavity. I know it does not go into the bladder, but it is deep down into the peritoneal cavity. What tube runs up till this much? This is a ventriculoperitoneal shunt tube. And like sometimes in a chest X-ray, if you're going to see like this, don't wonder what tube it is. It is nothing but a child who had a VP shunt. The tube will be like this. Why the tube is such a long? As the child grows older, the tube does not grow in length. So even if the child grows older, you can avoid a revision shunt when you are going to place in a longer size tube. So I told you multiple lines. Not only that, you can have the you need to interpret it with caution, like wherever tubes are, whether the tube is properly positioned, and whether if it is going to be a nasogastric tube, whether it is in the stomach or it has gone well beyond the stomach too. Sometimes you have mishaps too. When ICD has got no place here, someone thought that this is a pneumothorax and inserted an ICD. This should never happen. Sometimes we have something like a shadow here. We will think whether it is a pneumomediastinum here. It is called as a MAC effect. A normal X-ray sometimes will show a well-defined black line around the lateral margin, especially around the left border of the heart. This is only an optical illusion. It's an overlap of superimposed normal structure. It is nothing but your MAC effect. So we are coming to the last two slides. Just because I have shared my knowledge, I had given you advice, it does not mean I am smarter than you. It just means I have done more stupid stuff than you, like inserting an ICD into a eventration of diaphragm without even looking at the extreme eventration. And when I had looked at in the lobby, I was able to see the dome of the diaphragm near the second rib. Just because I happened to do an ICD, just because I followed the order of someone, I inserted an ICD in a child who had had an eventration of the left dome of diaphragm, thinking that it is a pneumothorax. But don't try to do mistakes, because as we get older, we know where mistakes can happen and try to avoid mistakes. The older you become, the less number of mistakes you do. This is what you call this an experience one. So I will call experience, whenever I say my experience, that means I have done mistakes, but I have learned from my mistakes. I don't want you to make mistakes. Without making mistakes, you get your experience from a person who had experienced that. So chest X-ray deals with shades of gray from white to black. Always read the X-rays in the X-ray lobby, not by looking through the tube light on a ceiling. This will allow you to make more number of mistakes. So kindly get up, walk up till the X-ray lobby and look at the X-ray in the X-ray lobby so that you don't make mistakes. And reading an X-ray is an art. It cannot be taught. So we have come to the end, but there is no end to learning. I want you to keep on learning. So I am ending here, Prasad and Raja. So whatever doubts you have, you can ask me. I've taken a long time, I think. 1 hour 45 minutes, 1 hour 50 minutes. I think it is too long at time, but I have told my experience. I have made mistakes, I have learned, but I have told my experience so that you don't make mistakes. Always try to read the X-ray in the X-ray lobby. I think that is what I want.
Thank you very much, sir. That was an excellent and exhaustive lecture. I think you have, within a span of 1.5 hours, like almost everything about X-rays you have given us, sir. Thank you very much. I request all the participants to post your doubts in the chat box, or you can also even raise hands so that I can unmute yourself and you can ask questions directly to sir, or you can even type your doubts in the chat box. So any doubts you can post in the chat box. Sir, I have a doubt from my end, sir. Like regarding this regular X-rays and the APR, PAVU, and lateral X-rays. When do we need to do lateral? Do we need to do lateral X-rays regularly? So like because even recently I had a case who was some 18-year-old male, like who presented with some vague cough and some compressive symptoms, something like that. Vague cough, just vague cough and some fever. We had evaluated, did a COVID swab and everything. Then took an X-ray. X-ray was almost looking like normal. Then we left it. Then again after 1 week, he had something like vague cough while swallowing. Then with doubt, we did a CT and we could find huge mediastinal nodes, necrotizing nodes. But we couldn't identify anything in the regular PAVU X-ray. Like, so should we make it as a regular habit to do a lateral X-ray, or like what do you recommend, sir? Like,
See, the problem is, if we are in a government setup, if the patient is not going to go away from you, yes, you have the time to take a lateral X-ray, see what is it, and then you can go ahead. If still you are not very sure, you can go ahead for your CT chest. But nowadays, we try to take the shortcut route. But in this child, definitely your CT scan is going to help you because therapeutic, your treatment decision is based on the findings. But you said this child was not recovering from the symptom. This has got a persistent symptom. Whenever you have a persistent symptom, this is what is going to make you start doing further investigations. And this has helped you by doing further investigation. And I don't find fault with you in doing a CT chest. Where possible, we can try to take a lateral X-ray chest. Suppose if it is going to be a posterior mediastinal like cyst, we'll be able to make out by the indentation what is going to be over the trachea, posterior wall of the trachea. If anything else, like as Professor Varinder Singh will say, the donut sign, like around the hilum in a lateral X-ray, if you're able to see, our donut sign is nothing but our medullae with a hole in the center. This is how your mediastinal nodes or the hilar nodes is going to give a picture all around the lower end of the trachea. So unless we start doing a lateral X-ray, we may not be able to appreciate the changes. Suddenly one fine day I do a chest lateral X-ray, I may not be able to pick up the finding. So that is why, in doubt, yes, you please go ahead and do a CT chest, no harm. But when it is indicated, yes, you go ahead and do, because you are not able to get an useful information from a frontal X-ray or from a lateral X-ray, or you are not able to decipher what is happening, the lateral X-ray, then definitely you need to have a CT chest. I don't find fault with you, but you can take a lateral X-ray. Unless we start doing a lateral X-ray, we are not taught about lateral X-ray in our PG time. That is why we have hesitation in doing, because we are not aware, we are not trained, we try to skip it. That's it.
thank you, sir. Like we have doubts, two of our participants have asked about X-ray changes in COVID children. Will we be able to pick up early COVID in a child with LRI with chest X-ray?
Very difficult because the ground glass appearance opacities are picked up only by CT because it gives a dimension which it gives the alveolar changes. So X-ray is not tuned to pick up small changes in the alveoli, in the interstitium. But CT will be able to pick up. CT is a better modality to pick up the ground glass opacities. But maybe X-ray is not that great to pick up the early changes in COVID. Why? Because COVID, your early diagnosis is going to make sure you isolate them, you put them on at least monitoring the saturation, find out what is happening, how much percentage of the lung is involved. Because CT gives you how much percentage based on whether it's 5 or 25 or more than 50 or more than 75. Your treatment, your place of treatment, everything varies. Here it's a life-saving one, this investigation. So CT is better than X-ray, especially if you have a child with COVID. At least it tells you whether you need to be alarmed or whether you need to shift the child to a higher facility, because the amount of changes what you see in the CT is much more than how the child is presenting to you at that particular point of time.
Thank you, sir. One more question, Dr. Solay Kumar has asked, how to differentiate CLE from CCAM in an X-ray?
Okay, both CLE and CCAM, they are going to have more air. CLE, lobar emphysema. Here, the air trapping, more air is going to be in one lobe, whether it's a left upper lobe or right middle lobe, or whether it's left lower lobe or right upper lobe. It is going to conform to the shape of one particular lobe only. And it is going to have compression of the adjacent part of the lung, whether it is the upper lobe or the lower lobe, okay, on either side. But CCAM, most of the time, it does not cause any compression of the surrounding area. It swells up. It does not take the form of a lobe. Probably you look at through if you're going to project the X-ray in the X-ray loggy, you may be able to find out, depending on the type, CCAM type 1, type 2, type 3, type 4, based on the type, you'll be able to make out if there are a large number of cysts, big cysts, you'll be able to see thin lines running across the cyst, multiple cysts. Sometimes it can mimic like a pneumonia, but it will not conform to any particular lobe or a segment. But when you are able to make out that there is no compression, but there is something going wrong, and you take an X-ray for a particular ailment, like you always correlate with your clinical findings, history and clinical findings. No fever, no tachypnea, but something else, you take an X-ray for a child who has got a cough and you have a picture like this, wherein you need to proceed further with CT to find out what type of CCAM it is going to be. Even for a CLE, your bronchoscopy is not going to tell you, even though you can have compression of the bronchial orifices before a surgery to make a definitive diagnosis. Here you need to have a CT chest, CLE. So CT scan is going to differentiate a CLE from a CCAM. X-ray can tell you whether it is a CLE or whether it's a CCAM. Now it is called as CPAM. But for a definitive diagnosis, to differentiate, better will be a CT rather than anything else. You can suspect, but for confirmation, when you are in doubt, you can go ahead with a CT.
Thank you, sir. One more doubt from Dr. Selvan, sir. Maybe in this current COVID situation, how do you approach a child with LRI of 2 days in your practice with normal SpO2? How do you go about it, sir?
I will only follow up the child because I do practice both in the morning and the evening. So I ask them, even though I know it is something like COVID presentation, usually with PP, we ask them to come in the morning. I check the saturation. I know, like, auscultate. I auscultate more in the back. I do auscultate the anterior chest wall too. I don't give leave to my stethoscope, because for me, the part in between both my earpieces are much more than any other investigation. So I'll try to auscultate, even though they say there is no place for stethoscope in your practice in COVID times. This is what one of the senior consultant had said, but I beg to differ with it, because any child who has got an LRI, I need to auscultate the lungs and try to find out, try to maintain the distance that I cannot maintain, 2 meter distance. At least I can maintain a 30 to 40 centimeter gap between me and the child I auscultate. So clinically, I don't do an X-ray, but if the child needs, if the child is getting worse, the symptoms are becoming worse, then I ask for an X-ray. Increase in the rate. Number two, either a decrease in saturation or both. Yes, definitely I ask for an X-ray. But because I practice both times in the day, I have the luxury of asking them to come in the morning and evening and checking them. When I ask them to come in the evening also, I tell them I'm not going to charge you because I do not know how your child is going to progress. So first thing, the moment you say, I'm not going to charge you, they are happy, because most of the people, they don't have money. So they will say, okay, doctor is looking at them. Anything is free. We always in the evening, I'll ask them to come in the next day morning to find out how the child is doing.
Thank you very much, sir. Thanks for joining us. I request Dr. Raja Agambram, sir, from Prolachi, to give the vote of thanks.
Thank you so much, Gauri sir. It was a very crystal clear lecture, right from basics. You are teaching us like teaching a kindergarten students. Thank you so much for taking us back to ICH days. Thank you, sir.
Thanks for the opportunity, and thanks for meeting my friends too. Like probably I'm just sharing my knowledge. Only 3 things has to be in circulation, as Dr. Thangavelu sir will say: blood, money, and knowledge. These things have to be in circulation always. Whatever I have experienced in my practice, I'm just sharing my knowledge and not teaching, because I make mistakes. That is why I'm just sharing my knowledge. But thanks for the opportunity.
Thank you very much, sir.
Right, Arun. Really nice. Okay.
Thank you, sir.
Thank you, sir.
Nearly 120 participants.
Wow. Great. Thank you.
Sure.
Okay.
Thank you, sir.
Bye.
Thank you, sir. Thank you, sir.
Thank you.